Welcome back, everyone. In our next segment, we'll be addressing another population which is highly impacted by young onset dementia. Those born with Down syndrome and other intellectual and developmental disabilities. We will hear from the nonprofit sector, from the primary organizations providing disease-specific education and support to those who are most affected by dementias under the age of 65. And if or when it is determined that someone with young onset dementia needs placement into care outside their home, we will hear the challenges that may affect their ability to do so. So I'd like to welcome Amy DeWitt-Smith from Northern Nevada, and she'll talk to us about her work with the Down Syndrome Network.
Hello, thank you so much, Helen. So did you want me going ahead and sharing my own screen, or are you pulling? Oh, there we go. Thank you. All right, so I'll try to be quick because I know we're trying to make up a little bit of time this morning. I just want to briefly review some population statistics for people with intellectual and developmental disabilities and what these numbers mean as we continue to support people with IDD as they age, and how long-term supports and services have evolved over the past century and where we are now in regards to both the challenges and opportunities for serving elders with IDD. So next slide, please. There were 7.39 million people with an intellectual or developmental disability in the United States in 2019. So of those, 22% or 1.58 million people were known to their state developmental disabilities agency. 19% or 1.4 million people received at least one long-term support or service in addition to case management. For every person with IDD getting publicly funded supports, 4 more people with IDD do not. The other 81% are being supported by their natural support network, so their parents, siblings, or other relatives. So what happens as a person ages and their natural support network ages, and they need additional support to remain living well in the community? What do we do? What do we do while we wait sometimes 15 years on a Medicaid waiver wait list? So next slide, please. So the total number of people getting long-term supports and services through state IDD agencies has doubled from over 700,000 in 1999 to over 1.4 million in 2019. This is a 192% growth rate within just the past 20 years. Next slide, please. I know this graph might be a little bit tricky to read, so I'll kind of go over it. The estimated number of people with Down syndrome living in the US has grown from almost 50,000 in 1950 to over 200,000 in 2016. This is a 435% growth rate. Why do we think this is? Well, today, people with Down syndrome are living longer and healthier than any other time in the past. In 1900, the life expectancy of people with Down syndrome was only 9 years. By 1984, the life expectancy had increased to 28 years. And since then, the life expectancy of people with Down syndrome has increased to almost 60 years. Remarkably, but not surprisingly, as we've moved people out of institutions and increased engagement, social connections, and created more person-centered supports, they begin to live longer. So next slide, please. So just kind of touch on Down syndrome and dementia a bit. By age 40, most people with Down syndrome evidence having plaques and tangles, which cause problems with how brain cells function and increase the risk of developing dementia symptoms. Estimates suggest that 50% or more of people with Down syndrome will develop dementia due to Alzheimer's disease as they age. Because people with Down syndrome are living longer, we can anticipate a much greater need for long-term support services to specialize in these co-occurring conditions. So kind of, going back to that number of people with IDD, including those with Down syndrome, who rely on a natural support network, it's really important that we consider this is the first generation where parents of children with Down syndrome will likely predecease their children. This is not something we as a nation had to plan for even just 40 years ago. Okay, next slide, please. This is my very highly skilled graphic design of the evolution of long-term supports and services. You'll see kind of how we've shifted to this more person-centered approach. But the first really formalized care was institutional care. So think, Willowbrook, where people received meds and 3 hots and a cot was pretty much it. Families didn't have a whole lot of options in the community. There wasn't really the belief that people with IDD were going to improve or learn or get better. Then we shifted to more of an intermediate care facility model, or what's referred to as an ICF. People still received 3 hots and a cot, but then we realized, oh my gosh, people with intellectual and developmental disabilities can learn. So there was this team of experts that kind of circled around the person, helped design goals, things like, measuring if a person could make their bed with at least 3 successes out of 7 per week. And now we're embracing home and community-based services. So we've moved people into communities where they can habilitate. It's less expensive, but often we've just created these mini institutions within 24-hour home models where activities, employment, and shared support services are segregated from the rest of the community. There's an inherent issue with long-term supports and services for people with IDD being habilitative. So meaning that a person must either acquire a new skill or maintain their skills. As people age, they're less likely to be able to maintain and acquire skills. In most communities, this has meant that people with IDD are prematurely leaving their homes, their families, friends, pets, and neighborhoods to go into 24-hour homes or facility-based care. Next slide, please. So at the risk of using this rather kind of cringy ageist term, silver tsunami, it really is almost like, a Paul Revere reenactment. Just a decade or so ago, Aging Service Networks exclaimed, "The boomers are coming, the boomers are coming." And as we all braced and raced to manage the result of an LTSS system that was projected to burst at the seams, we saw senior village models erupt, a greater national focus on caregiver support, and attempted to navigate the increase in need within a generation of people who are going to age on their own terms. However, during all of this innovation and discussion, we struggled to fit people with IDD into the bigger long-term support and service system. So, kind of some of our current challenges really revolve around limitations with IDD waiver programs. Again, that, requirement for services to be habilitative. It just doesn't work as people age. Really long wait lists, thinking about that 81% of people who are not currently in the state service system, and those natural support networks are aging. And as they and their support go away, we have to be able to address the needs of people who need that long-term support. There's that lack of funding, and of course now, post-pandemic, poor provider capacity and workforce challenges. Special populations require individualized support. So people living with dementia who have IDD, as well as mental health conditions, people of color, people living in rural and frontier areas, as well as in tribal communities. And then the idea of caregivers and how it's defined. So caregivers of people with IDD do not see themselves as caregivers or even care partners. Their role is really more of a familial role. It's based in a lifelong commitment to providing care and support to their loved one. They've had this habilitation mindset, so they've thought about how their loved one, usually son or daughter, or brother or sister, is going to improve and grow and progress in their skills and their knowledge and understanding of their environment. These are families who have been fierce advocates for their son or daughter's entire life, challenging school systems and service programs and making sure that they have what they need. So when we look at even the training and support that's created for the care partner of someone living with dementia, it's not as suitable for that primary support person of someone with IDD and dementia, because those relationships began in a very different way when you think about it. So, a lot of care partners of people living with dementia are either spouses, where that relationship began early on as a partnership. It was reciprocal. Or even people living with dementia who are supported by maybe their adult child. And in that relationship, it began with, well, you raised me, and now it's my turn to reciprocate that support. Care partners of people with IDD and dementia, they already know how to care give. So, having training programs or support systems where we are teaching people how to suddenly be a caregiver comes off as kind of patronizing, because they already know that part. The part they're struggling with is the changes in their mindset. They can no longer look at that habilitative mindset where their loved one is going to continue to progress and to grow and to learn, but actually dealing with some of the reality that dementia is causing them to lose skills and not necessarily maintain. They're also coping with their own mortality and that fear of what happens once I'm gone. So there are some opportunities, kind of really redefining and redesigning long-term support services for people with IDD to be less habilitative as they age. So progress being based on meaningful engagement and acceptance. And shifting current funding to further support people living in their own homes, with their families and in their neighborhoods where they want to be. Really creating respite care programs that provide hands-on support to that primary support person, even shared living models where family members can be paid to be that primary support person, increasing the availability of day programs that aren't connected to that habilitation. And then, of course, IDD and dementia training to ensure that environments are enabling versus disabling. So, really teaching both paid and unpaid caregivers about how a person's lived experience evolves as dementia progresses, and then continually identifying ways to help people live well with dementia. Okay, next slide, please. So given what we know now, what would the prognosis be for a person with IDD and dementia if we were better able to support them in the community, in their own homes, with their family, pets, and friends, and neighbors they know and love? How much longer would they live? How much better would their outcomes be with greater access to healthcare, early diagnosis, and services to support their families? How much more meaningful would people's lives be? And then I did include just a slide. The next slide just lists some resources or sources that I used for this presentation. And then the last slide, if you want to connect, this is my email here and my website for the nonprofit that I work for, Neighbor Network of Northern Nevada. Hopefully I did okay on time there. Got us a little bit caught up.
Amy, you've done great. Thank you so much. I really want to highlight, though, I really appreciate the fact that you put in the statistics. It gave us actual numbers. The numbers on young onset are separated from yours, right? When we talk about young onset dementia. And so these all need to be brought together within the same framework generally. And so what you've brought here today is incredibly informative to the panel. So I appreciate that. So if you'll hang with us when we're going to go further into this presentations, and then hopefully you can stay with us for the discussion. Thank you.
Thank you. Will do.
All right. So we're going to move on and have presentations by organizations that are serving the three main diagnoses categories. We're going to be talking with those from the community representing frontotemporal dementia, Lewy body dementia, and Alzheimer's disease. And we'll be starting with Matthew Sharp of AFTD.
Thank you, Helen, and thank you so much for the opportunity today to talk about FTD and young onset dementia. And thank you to the council for taking on this really difficult subject. I'm going to go through a sort of an overview of what FTD is and focus on how it's different than the other dementias. But I've been struck so far today by, again, how the challenges that people living with this disease and families and care partners face, regardless of the underlying causes. The age of onset in dementia makes such a big difference. So next slide. And like I said, I'll focus on the differences and try and give a general overview. Next slide. So how does FTD compare to the other dementias that are part of NAPA? It is much less common, obviously, than the other dementias, but it's also widely thought to be grossly underdiagnosed. So there's probably many more people out there with FTD than we are aware of. And this lists some of the more characteristic features, but one of the aspects of FTD that I always go back to is that it is so variable and heterogeneous. We think of it as a young onset dementia, but the age of onset can span from as young as early 20s to people's 80s. So it's a really just complex disease. Next slide. So we use the term frontotemporal degeneration really as sort of an umbrella term that covers a complex of over 8 different clinical diagnoses. These are split into 3 main categories, I guess. And on the slide here listed the actual clinical diagnoses that go under in each category. So even though we split these into categories according to what the primary symptom groups are, whether it's behavioral, whether it has to do with language and communication, or whether it's related to motor function. As the disease progresses, symptoms change over time. So even though they may start in one category, the norm is that things blend as the disease progresses. Now let's take a closer look at each one of these categories. So next slide. So the frontal lobe, that's the part of our brain where, personality and executive function lie. Some of the real challenging symptoms related with what we call behavioral variant FTD include things like apathy. So when people really just sort of lose an interest in just about everything, as well as you see a lot of behavioral disinhibition in FTD. This includes things like loss of social restraint, people being uncharacteristically rude or offensive, people just sort of disregarding laws, doing things like shoplifting, touching strangers, and sometimes making inappropriate remarks, as well as aggressive outbursts. And so it's easy to see how that combination or that class of symptoms can lead to a whole range of different social personal problems. But another primary symptom in behavioral FTD is a loss of sympathy or empathy. We hear stories about people getting the news of losing a loved one and then asking to go to the store because they need some candy or something like that. On top of this all is something called anosognosia. Basically, that means the loss of the ability to recognize symptoms of a disease. So in the case of FTD, where the symptoms are behavioral, people will can display all these ranges of symptoms without having any awareness that they're doing something odd. And this is a real variable part of FTD. We used to think it was more characteristic, but in talking to people living with this disease, it's a fascinating range of awareness of their problems. Next slide. So the second part of the term, the temporal lobes, that's where our ability to understand and use language lies. That's also includes, visual memory, memory of pictures and shapes, as well as understanding words and names and sorting new information. So when FTD or frontotemporal degeneration starts in the temporal lobe, it usually presents as what we call primary progressive aphasia, or PPA. And then PPA is further divided into 3 different subtypes. The non-fluent agrammatic variant has to do really with the ability to produce speech and produce comprehensible and fluent speech, as the name implies. Semantic PPA is related primarily to a loss of word meaning. And then logopenic PPA is characterized by slow speech, but grammar and vocabulary and understanding are generally preserved. And often people with logopenic PPA are unable to repeat phrases that are said to them. And will sometimes make sound substitutions where they'll use a word that rhymes with the word that they're thinking of. And then to sort of make things, a little bit more complicated, the pathology underlying logopenic PPA is often actually amyloid. So technically it's a form of Alzheimer's disease. So next slide. And then we have the motor symptom, the motor disorders. So that includes cortical basal as well as PSP. In PSP, both of these conditions are often also thought of as atypical Parkinson's diseases. Often when people present with CBS or PSP, they will be diagnosed with Parkinson's and then treated for Parkinson's, but those medications will have no effect, which is sometimes how the diagnosis of these motor disorders is made in FTD. Next slide. And finally, there's FTD, the overlap between FTD and ALS. So the discovery in 2011 that the C9orf72 gene can cause both FTD and ALS changed that long-held belief that ALS is purely a movement disorder and FTD is purely a cognitive behavioral form of dementia. People with this mutation in this gene can present with either FTD or ALS. So it's a real complex mix of presentations, even though it's connected to the same gene. And it's believed that as many as 20 people with FTD will develop signs of ALS. And likewise, approximately half of the individuals diagnosed with the most common form of ALS will show neuropsychological symptoms and cognitive decline. So early detection and careful monitoring of cognitive effects even in ALS patients is a real crucial part for finding patient and caregiver supports. Next slide. So another important feature of FTD is that it is often genetic. Most cases are what we call sporadic, so there is no family history. But approximately 40% of people fall into a familial form of FTD where there is a family history of dementia, even though it may not be diagnosed as such, going back in history especially. But the presentations can also be somewhat different. And then there are what we call genetic FTD, where the genetic underlying genes are identified and the mutations are known. The majority of genetic forms of FTD are related to 3 different genes, C9orf, as I mentioned, the progranulin gene, GRN, as well as the MAPT gene that's involved with the tau protein. Because of this genetic aspect of FTD, it has advantages for research, and these genetic families play a really critically important role in developing therapies and biomarkers and everything that we need in order to master these diseases. So next slide. So now I want to touch on the impact on families. A lot of, next slide. What I was going to say has already been said in a variety of ways. And I think Katie Brand actually mentioned this paper specifically. So back in 2017, AFTD funded an economic burden study in FTD, and the results are shown here. And again, because of the earlier age of onset, a lot of the costs and financial impacts of FTD are kind of compounded by the fact that people have to stop working, and not just the person with the disease, but also care partners and family members. And not only does there a financial impact on the family members, but also a physical and health impact with a lot of health implications of being a caregiver. Next slide. So, without any FTD-approved treatments in FTD, caring for the person and the family with the disease requires pretty much a team approach, right? That people have to figure out how to navigate a really complex system of different services, and be able to act as the center of all of that and organizing it and coordinating it all for the person who's living with the disease. So we often say that everybody, care partners with FTD really do have to become experts, not only in the disease itself, but also in the service systems that they're relying on for health. Next slide. So I want to just provide a quick look at some of the resources AFTD provides and offers. Next slide. So we do have a variety of different publications, as well as a few small financial grants for both people living with FTD, as well as care partners and family members. We manage a network of support groups that are specifically for FTD across the country. I think we're probably close to 90 at this point. I don't know the exact number, but we provide education and support to the people who lead these groups, as well as try and steer people to the groups when we can. And all of this is accessible through our helpline. Our helpline, the 866 number there, or the info@ email address, is really sort of a front door to everything that AFTD offers people. Next slide. And a growing aspect of our work is providing education to healthcare and medical professionals. So we've produced a couple of diagnostic checklists for both BV, FTD, and PPA. We have a newsletter specifically for healthcare professionals. And we've been working on a series of webinars with continuing education credits for healthcare professionals, all of which are accessible through our website. So next slide. All right, so thank you very much. I know that was sort of a whirlwind tour, but hopefully we'll be able to answer some questions as well. So, thank you.
Matt, thank you for this really comprehensive overview. Really sincerely appreciate it. Now it's well informed, our audience. Now I'd like to move on to Lewy Body Dementia Association and their representative, my dear friend, Brandy Hackett.
Hi, everyone, and thank you so much for this opportunity to be here today. First, I want to say thanks in reverse to Helen, as well as Brother John Richard, for sharing their lived experience specific to the diagnosis that we support here at the Lewy Body Dementia Association. And again, my name is Brandy, and I lead support here as our senior manager. Next, please. So as Matt did, I want to share a little bit about Lewy because I feel like it is a diagnosis that is frequently misunderstood. And so for our diagnosis, it is a progressive brain disease that is due to the accumulation of certain proteins in the brain that end up creating something called a Lewy body that causes the disruption and some of the symptoms that we'll talk about briefly. It was originally discovered by a neurologist, by Dr. Lewy, and that's where the name comes from. And it is a label that encompasses two different conditions, both Parkinson's disease dementia and dementia with Lewy bodies. And the difference is when the symptoms of Parkinson's or movement changes surface. Next, please. In terms of statistics, it can be an incredibly misdiagnosed form of dementia, and we see this very, very often with those of younger onset especially, but we see it too with those of all ages. Often they will be categorized under different mental health diagnoses. We will see other dementias such as Alzheimer's, as well as the back and forth between the clarification around Parkinson's. At this point, it is at 1.4 million Americans that are affected. And for many times, it is over the age of 50, but we do support many individuals that are diagnosed at a younger age. It is the second most common cause of progressive dementia after Alzheimer's and can be an incredibly expensive form of dementia for some of the reasons that we'll talk about today, but often is because of the rapid onset of different symptoms as well as care needs that surface. Next, please. As many dementias are, there are so many barriers to a clear diagnosis for the individuals that are experiencing these symptoms and those that are loving and supporting them. And what we find is this dementia can look, although similar in patterns of symptoms, can surface very differently for different individuals. And so sometimes they can show up with different symptoms. We'll call it banging a louder drum, and at different points, often experiencing certain fluctuations. Sometimes the symptoms are what we'll call taboo in conversation. And so if a person is experiencing something like a hallucination, they may not share something like that with their family or with those that are supporting them medically. And sometimes there is a change in insight. And so we've had a couple situations where some of the experiences or symptoms are normalized or may be parts of other conditions. And so there may not be as much insight that certain symptoms may be related to this more umbrella diagnosis. And we're also facing some of the challenges as the other dementias, where often the clinicians aren't as familiar as they could be. And so we do find this an incredible place of learning for our medical community to really share how complex this diagnosis can surface, as well as the diagnostic criteria. Often, especially in smaller areas, there may not be specialists that are available. And so trying to get this information to all levels of healthcare. And so there may not be different levels of testing or support to help to clarify the diagnosis. And at current, there isn't a widely available biological test, but we are very excited to see what is coming in research to help to continue to clarify this diagnosis through tests and screenings. Next, please. And for someone to have dementia with Lewy bodies, which is, again, one form of our dementia, there has to be sort of a variety of changes. And we see this with cognitive decline. And I love Dr. Melissa Armstrong says cognition is changes to our thinking and memory. And for those that are supporting this diagnosis, often those changes show up differently than a lot of our screening tools or smaller screening tools may even detect. And some of these cognitive changes, as you're seeing sort of towards the end of the slide, can have these incredible fluctuations. And so for those that I support, they describe having sincere moments where they feel, we will call it like their prior selves, and other moments where the struggle is just so real. And care partners looking in from the outside of those experiences will say the same things. And so there's these variations and levels. And this can be especially hard because, as Brother John Richard mentioned earlier, today he is blessed with a good day. And in moments when the days aren't as good or the moments aren't as good, you can see such a shift in and how these symptoms are presenting. We also see Parkinsonism, visual hallucinations, and REM sleep behavior disorder. So as you'll see on the slide, the symptoms can be quite unique to our dementia. And so for those that are experiencing visual hallucinations, this is very often something they have never experienced before. And for our care partners, it's often something that they're not supported before. And so in symptoms like REM sleep behavior disorder can surface sometimes decades before other symptoms. And so again, there's just such complexity in this diagnosis. Next, please. And I love, this is a slide from my dear Helen that really does show the complexity and how the symptoms and where the symptoms can show up in these different sections. And so we do see changes to thinking and memory, changes to sleep, autonomic, or the way that our brain processes these automatic things that our body does, like regulate our temperature or our blood pressure. Sensory, and this can often show up in even changes to things like vision, motor. So again, going back to those connections with Parkinson's and movement changes, how it can show up in the body and change the person's ability to do for self. as well as the neuropsychiatric. And so we'll see in that the hallucinations that were mentioned. We'll also see delusions, those fixed false beliefs that can really become what is reality to that individual, as well as things like illusions or misperceptions where the brain is just lying. And so often the person is responding to the brain lie in the way that many of us would. And care partners are struggling to support because to them it's not true. And so there's such a balance in how these symptoms surface. And again, we see it, sometimes I'll describe it, it's almost like a really terrible DJ board. And so all of these symptoms have different sliders and different knobs. And so every day it can look and feel different, and can look and feel different from person to person. Next, please. And so how does this show up for those of young onset? And so it's really easy to connect that some of the symptoms that I've talked about today can show challenges to both the person that are experiencing the symptoms and those that love and support them. And so when it shows up in these motor or movement changes, issues in walking, stiffness of muscles, we have so many individuals that experience falls. And what a scary space to be, thinking that if you're alone, experiencing a fall, or thinking that a fall may lead to the next level of care for that individual. The cognitive, and again, these changes to thinking and memory and attention span, changes to visuospatial and the way to really interact with the environment, and then the fluctuations in that. So it's not only the presence of the symptoms, but it's this roller coaster ride of where and how it can show up. The mood, apathy, and this can stand alone beyond depression, but just an inability to motivate or feel motivated to experience joy and engagement in the way you did before. Depression, anxiety, going back to that autonomic or those automatic systems. So having these blood pressure fluctuations, and again, things like that can affect things like fall risk, changes to a level of incontinence at all ages. And so how many of these symptoms require a shift, not only to who you know you are, but how you engage, what you enjoy, and how you interact with your environment and your community. Sleep. We all know how critical sleep is to our everyday. And so these interruptions, not only for the person that is diagnosed, but also for the person that may share a bed with them, can really shift, again, a lot of the ways that you feel energized to meet the next day. We find that in our dementia, these activities of daily living, the way that we dress ourselves and groom ourselves and bathe ourselves, and the support that we need in all of these activities too, can be affected much sooner because of this interaction of all of the symptoms that I mentioned, as well as some of the acute changes that can happen very quickly. Next, please. So if we're digging into some of the specifics, really these altered perceptions, so with the brain lies that can happen with this dementia, the hallucinations, seeing and hearing and tasting and sometimes feeling things that others aren't experiencing, the illusions, our brain telling us that things are certain things when it's not those things, the delusions, those fixed false beliefs that can enter in and become our truth. These are often misdiagnosed. And so, for many people, if I say the word hallucination, they don't automatically jump to a dementia. They often jump to mental health diagnoses such as schizophrenia. And we'll find that some of these changes to altered perceptions can happen very, very early. And for some, they can be some of their first symptoms. And so again, often, as a dear friend in Atlanta says, we're often thinking, especially with younger onset, that it is psychiatric, not neurological. And so with ours, having that shift and really facing those physicians that are trying to convince us that what we have going on really is a change to psychiatric conditions can be really unsettling. For medication sensitivities, once the diagnosis is there, the symptoms are there, really trying to find the balance in how to treat the symptoms and sort of how to treat the symptoms in a way where the side effect profile is as livable as it can be. And it often can be a really acute balance of finding the right fit in terms of the meds that can be available to help the symptoms. And we do know that some of the symptoms in what we would call a normal toolbox of meds. So if we go back to the hallucination, The toolbox of medication for hallucinations are often a medication class called antipsychotics. And so some of the meds in that toolbox aren't appropriate for our dementia. And so part of this is the education, not only for the individuals and their families, but also for the medical providers. And so again, it is that balance in terms of meds for treatment once the symptoms present. Next, please. And I'm so grateful that we'll be talking about placement, because we do find so many difficulties here specific to age-related restrictions or a facility's experience. We have so many individuals and their families that call to say, once they learned that I had this diagnosis, it was a big no for us. And so sometimes they aren't even given the opportunity within certain placement organizations because of that placement's potential history of, or that corporation's guidance around acceptance with this diagnosis. There's often a lack of staff-specific training to dementias, and specifically dementias outside of Alzheimer's. And so really helping the staff and those that support, who really, as I find, want to do a good job. They just don't always have those tools in their own toolbox to help and support and understand. We also see that for those that are facing this, and I love Katie mentioned, and it's been mentioned a couple times, the world changes. And often in those changes, the supports, whether that be through their employer, through their faith organizations, through their friend groups, people sort of disappear. People don't know how to support. They may not know the right things to say or the right things to do. They may approach in a way that can be seen as offensive. And so often is such a shift in not only the isolation that one can find with this, but also how to manage and continue to engage with not only their social supports, but also, again, the supports within their community. We find, and there's some work going on right now, and we love to see in faith communities, just getting to know dementias better so that they are more prepared to support. We also find that the supports specific to understanding lived experience, and I can tell you how rare it is to have two individuals in this one room. But what we find is those in the community have a very hard time accessing, connecting to others that get it. Connecting to others that I say can hold the flashlight for them on this journey. But we do have a great program called Louie Buddies, which I'll share a little bit more about shortly. Next, please. So why should care providers in long-term care and services know more about LBD? And it's really because they need to receive the right information. They need to be able not only to know it, but to be able to provide it back. This helps with clarified diagnosis, medication management, increasing access to research, supportive techniques, and it gives everyone in the system a way to support. And it also helps the person who is experiencing the symptoms and those that love and support them feel visible. And Brother John Richard, I love that you use that word, because for us, it can be a sense of invisibility. We also want care providers to be able to connect to local resources, learn about appropriate levels of care, financial resources that are there, and really learn to advocate. We also want that staff members to understand and proactively reduce risk, not only for those individuals, but also for their own staff, to help and reduce and prevent staff injury, to also help with cost savings and patient outcomes and risk reduction, but also for those individuals to reduce things like fall risk, issues with emergency planning, crisis intervention, and their overall safety. Next, please. And so what do we do as an organization? So we really do try to support from all angles. And so that's helping people connect to education, outreach, research, and support. Next, please. And so we have a tremendous amount of educational resources, both in some in print, and we have so many on our website. We also have a beautiful new program called our Louie Learning Center, which will help individuals engage directly with videos and additional support specific to topic. Next, please. Our volunteers, they are sincerely the backbone of our reach, being such a small organization, but we have a beautiful network of available resources. And we have those through support groups that are offered nationwide and that are volunteer ran. We also have groups for those that are diagnosed. We have a Lewy Buddy program, which is similar to some of the ones that we've heard about today, where it's peer mentoring, where it's pairing people that are either current or prior care partners with care partners now on the journey, those that are currently diagnosed with others that are diagnosed, to really find that direct support and peer mentoring. And that really goes beyond what we can provide here as staff. Next, please. And so lastly, the best ways to get in touch with us. And like Matt said, our Lewy line, which is our helpline, is a great way to learn more and to get in touch with all the things that I've mentioned today. And you can do that through our Lewy line listed here, as well as our support email. I appreciate the time. Thank you all.
Randy, thank you. Yeah, having been on this journey as long as I have with Lewy, and for having you absolutely express in so many ways the complexities which so many people, all the way from medical providers through, obviously through the general community, have no idea. So it's going to be interesting as we go further into discussion to see that each of these dementias need timely and accurate diagnoses and support, because they are all distinctly unique. So we're going to proceed on, and we're going to bring in Monica Moreno from the Alzheimer's Association.
Hi, thank you. And it's a pleasure to be with all of you today. I thought I would start next slide, please. One more slide. Thank you. I thought I would start first by defining Alzheimer's and dementia, because these terms tend to be used interchangeably, and while they are related, they are not the same. You know, dementia is an umbrella term that is used to describe changes in a person's memory, thinking, and reasoning that starts to affect their daily life. And Alzheimer's disease is a progressive and fatal brain disease for which there is no cure. It is the most common form of dementia, and it accounts for 60 to 80% of all dementias. There are other types of dementias, as you heard from Matthew and Brandy, but I think the biggest takeaway for families is that when your family member is diagnosed with dementia, it is critically important to understand what type of dementia have they been diagnosed with. Next slide, please. So today we know that there are approximately 200,000 Americans who are living with younger onset dementia. They range in the age of 30 to 64, although individuals in the age range of 30 to 40 is very rare. And the average age of individuals living with a diagnosis of younger onset dementia is 49 years of age. Next slide, please. Now, I did want to touch on some of the unique challenges that those living with younger onset dementia experience. And I just want to stress that these are not unique to individuals living with younger onset Alzheimer's disease, but it certainly crosses over to the other dementias as well. Now, for the last 13 years at the association, I've actually been able to work very closely with our National Early Stage Advisory Group. And this is a group of individuals who are living with mild cognitive impairment, Alzheimer's disease, and other forms of dementia as well. They represent those living with younger and older onset dementia, and they advise the association on the types of support services that are needed to help meet their unique needs. We also work with them to elevate their voices with legislators, researchers, and the media in an effort to raise awareness of what is it like to live with dementia and younger onset, but also at the same time really work to reduce stigma. And so in my conversations over the last 13 years with those living with younger onset, when we talk about what were some of the initial warning signs that they experienced, many of them talk about the fact that they were working at the time that they started to notice their symptoms. Tasks that they were able to complete that were very easy for them to complete were now becoming more difficult. They may have been experiencing challenges with executive function. Some talked about how they were now working longer hours, 12 hours a day, in order to complete the same amount of work that they were able to do in a less number of hours. And one advisor had shared with me that he was actually forgetting the discussions at staff meetings that he was leading. Therefore, he would ask his colleagues to share their notes to help jog his memory. And certainly when we think about getting a diagnosis, we know that the greatest risk factor for developing Alzheimer's disease is increased age. And so it's not uncommon to hear from those living with younger onset dementia that when they have approached their doctors about memory concerns, dementia is not in the forefront of these conversations because of their age. I had an opportunity to speak with a group of women who shared that when they expressed concerns about their memory issues, their doctors told them that it was attributed to menopause because of the age group that they were in. For others, they talk about how their doctors told them that their stress was probably attributed to work. And so, lighten your workload. And so again, doctors may not be thinking about dementia with these younger individuals. And as one advisor shared to me, we are young and we look healthy and we look strong. And again, dementia is not really in the forefront of those conversations. But all of these challenges can certainly create barriers to getting an early and accurate diagnosis and can lead to misdiagnosis not only once, but multiple times. Now, when we think about the symptoms that an individual may experience while working and getting a diagnosis, I've heard stories of individuals talking about how they were very high performers at work, and then suddenly they were put on a performance plan. Some individuals may have been fired from a job or multiple jobs because they were having challenges carrying out their job responsibilities or even learning new roles and responsibilities and new information in a new career. Some talked about the stress that they were experiencing and trying to manage the workload, and it became so stressful that they had to either quit or they had to retire early. And we know that when an individual has to leave their job too soon, they may miss the opportunity to benefit from their employer's short and long-term disability, as well as COBRA insurance, which allows them to maintain their health insurance, not only for themselves, but for their family, and certainly at a time where health insurance is critical, especially given the new diagnosis that they're being challenged with. Next slide, please. Now, there's also a financial impact to these families. Losing a job or having to retire early can be catastrophic to these families, especially because many younger onset families still have financial obligations that those who are older may not have. They may still have to pay their mortgages. They may have car payments and college loans that they still have to pay back, as well as any of the expenses that are related to raising a young family. Certainly in thinking about retirement in the future, they have not had the opportunity to work 30 to 40 years to be able to set aside funds for their retirement, and certainly not being able to address the financial cost in the event that their care needs, well, we know that their care needs are going to grow and those costs are just going to continue to increase. And certainly for care partners and other family members, it's not unusual that some of them may have to go back to work. Some of them may have to take on additional jobs because of the loss of income of the individual living with dementia, who may have been actually the primary breadwinner for that family. And then for some families, they have to really make significant lifestyle changes, whether it's downsizing or selling their home. I actually had worked with one of our advisors, and her husband had shared that they had sold their house because they were not able to maintain financially the cost to keep the home, and they had to rent an apartment. And so he was still working full time, but he also took on an additional part-time job to actually do the maintenance around the apartment complex so that they could get a reduction in their monthly rent. And unfortunately for some families, they may have to actually file bankruptcy. Now, we do know that those with younger onset are eligible for Social Security disability. And this is great because it provides them with that, at least a portion of that lost income. However, there is a 2-year waiting period from the time that they start to receive Social Security disability benefits that they are then eligible for Medicare. And when you think about a 2-year span in which you do not have health insurance, many times the care partner will have to go back into the workforce in order to just have medical coverage and insurance coverage for themselves, as well as the person living with dementia. And then I just want to mention one other unique challenge, and this really came up more recently in my conversations with some of the nominees to our next advisory group, that many of them have talked about their desire to raise their hand and want to participate in clinical trials. They want to do something and they want to be part of the studies to hopefully find a cure. However, many of them have expressed that when they reached out to the clinical study sites, they found that they were too young to participate. And so this is certainly an area I think that we can work to try to resolve, because we have willing participants, and I know we're always struggling to try to get people to participate, but this certainly is a barrier as far as their age. Next slide, please. Now, we know that dementia does not just impact the person who's living with dementia, but it really impacts the entire family. And for many of these younger onset families, they're still raising very young children. And these children can experience changes in roles and responsibilities. And certainly at the same time, they're dealing with the emotion of coming to terms with losing the aspects of the parent that they once knew. We have already touched on the challenges and the changes in roles and responsibilities of the care partner. And certainly as dementia progresses, they will find themselves in the role of having to provide more care, provide the financial cost of that care, but also having to manage the household, and as well as if they're still raising a very young family. And then as far as adult children, we know that this can be the sandwich generation, but I have had the opportunity to talk with adult children who've had to make very difficult career choices. They've either had to decline promotions or make the decision to move back home in order to be able to help provide care to their parents. And I actually spoke with a daughter who shared a story that when she was in her career at a younger age, she was making a very lucrative salary, and her mother was diagnosed with dementia. And she made the difficult decision to have to move back home, which was a very small town. She was able to find a job, but it did not pay nearly what she was making. And years later, as I was speaking to her, she was thinking about the fact that, how was she going to retire? Because she did not have the opportunity to save as much as she would have liked to had she stayed in her career and not moved back home. I will say that she didn't regret having to do that, but it was just something that she knew was a consequence of the difficult decision that she had to make. Next slide, please. And then I just wanted to end by sharing resources that the Alzheimer's Association offers to those who are living with dementia, but certainly those who have younger onset as well. All's Connected is our online community. We have over 20,000 active members on the site, and we have a community specific to those living with younger onset, as well as care partners and caregivers. We also offer an array of education and support services that are delivered through our nationwide chapter network, and we have education programs as well as support groups that are geared directly to those living with younger onset because of the very unique needs and challenges that they experience. And then what I like to call is our crown jewel, our 24/7 helpline. We have helpline agents that are available night and day to answer general questions about dementia, but we also have master level clinicians that can provide care consultations and help families and those living with dementia develop an action plan. So more information can be found around all of these resources on our website, which is at alz.org. Thank you.
My goodness, Monica, thank you for bringing on a lot of topics that were kind of touchstones for me. The issue of accurate diagnosis, the uniqueness of each of these, and having to push through dementia is dementia when you hear that from clinicians. So the other thing, the issue of gender bias in women. And so I know that story very well and intimately and personally. So I hopefully that will be part of our discussion when we get to our discussion period. And so now we'd like to move on, though. I'd like to welcome my fellow NAPA Advisory Council member, Deek Cateau. And Deek, I'm going to let you take it from here as we talk about long-term care settings.
Thank you, Helen. I am surprised that we haven't heard any stand-between stories today. The stand-between stories, what I'm going to give now. I stand between you guys and the break. So I would do my best to get through this quickly. I am the CEO of an organization called AG Roads out of Atlanta, Georgia. We operate 3 nursing homes in Metro Atlanta, Georgia. We serve about 1,100 seniors each year. The rest is self-explanatory. I want to acknowledge one of my board members, Dr. Monica Parker, and it's ironic that we are both here today. She presented yesterday, and I think her presence is so important. She was, several years ago, our first board member of color that my 120-year-old organization has ever had. But more importantly, she was not brought on our board because of her color. She was brought onto our board because of our expertise in dementia care. And I think my organization's very noble mission, realizing, hey, we've been doing this wrong for a long time, and we need to take care of the most vulnerable among us, which I'll tell you all a little about later, and that is those living with dementia. I heard some discussion about this earlier. And one of the wonderful things about NAPA and this organization is we talk a lot about research. We talk a lot about the great strides being made into finding a cure for dementia. But someone said earlier, we cannot forget that while we are searching for this elusive cure, we have millions of people living with dementia, hundreds of thousands and even more living with young onset dementia. And we have to, I think, reallocate some of those resources to caring for those individuals. Long-term care plays a big part in that. Housing is health. Lisa, in one of her slides yesterday, spoke about some of those healthcare, inequities, and housing, healthy environments is really a key determinant of good health. And I think sometimes when people talk about residential living, nursing homes, assisted livings, sometimes we forget that big housing part of it. So not only do we take care of individuals who are ill and have diseases and illnesses, but we also provide a critical role, because a lot of these individuals, without our environments, would not, have anywhere to live, have anywhere to stay. We've become a social security net, a safety net in many cases. And that's not necessarily a bad thing. I think, though, it is a net that we need to fix and we need to adjust to ensure we are properly taking care of those people who are most important to us. So I think it takes a village. We heard great conversations yesterday. I mentioned that yesterday. And I think we cannot forget the critical part that long-term care services play in that village. Admittedly, today I'm going to talk a lot specifically about nursing homes. Most of what I'm going to talk about is nursing homes because that's the place I'm in. But I'm also going to speak and give you all some data on assisted livings and other residential environments as well, as it pertains to younger onset dementia. So this slide is self-explanatory. In our nursing homes today, about 16.5% of our residents in general are under 65. And in assisted livings, about 6% are under the age of 65. So it's not a huge number. I can tell you that it is they say it's the fastest rising demographic in nursing homes. Still not a huge number, but it's rising very, very quickly. And we have a lot of work to do to get to that point. In my nursing homes, which today have about close to 400 residents today in our occupancy, we only have 3% of our individuals in my nursing homes today living with dementia under the age of 65. And as part of my preparation for this, I made it a point to go and meet these 3% of these residents. And hopefully we'll talk a little bit about that. And I'll start with an admission. As great work as we do at AG Roads, I do not think that younger onset population, we are doing enough to care for their needs socially and otherwise. It's not our fault. So I'm, to the audience, don't blame the nursing homes for it. As someone again said earlier, we're just not equipped for it. And with that small percentage of a population, it obviously becomes more difficult to do. A little bit of what I said earlier. This is McMaster University, percentage of residents 18 to 64 in residential and long-term care facilities has increased. It is increasing. Younger residents are feeling isolated in these centers and they're ill-suited for them, may develop symptoms of depression. A lot of that is what I saw from the individuals I spoke to. One of them, I actually encouraged her to, the nursing home may not be the place for her. She luckily has, I think, some access to resources that can probably see her in a better suited environment. But definitely, I think nursing homes, assisted livings in many cases as well, may not be the right environments. All right. These are some AG Road statistics as for individuals to understand. 60% of our residents have dementia, and I say / cognitively impaired. We have a huge sector of our resident population that are simply not diagnosed. We see a lot of the attributes that we think may, and we try our best then to give appropriate care and fall in a care plan related to dementia. But many of them are undiagnosed, and I wouldn't belabor why that is. We've discussed a lot of that yesterday: access to primary care, access to proper diagnosis. On the right, we see 48% nursing home residents. This is Alzheimer's Association data. 42% in residential care centers, assisted livings, otherwise. Home health, 32%. And a very important piece here, 30% in our home care recipients. The graph on the left, David Grabowski, who's one of the top researchers in our sector, nursing home residents younger than 65 are unique and would benefit from targeted policy making. He actually played a big role in the recent NASEM report on nursing homes, and that was one of their findings as well. That targeted policy, which hopefully would come out of things like this, needs to be looked at. Of that, almost 40,000, the overwhelming majority of that 50 to 64 age group, and that's the group that I find are left out in nursing homes. We discussed over dinner last night that I think nursing homes actually have and assisted livings have embraced intergenerational programming, but that is typically the very old, the very young, teenagers, and that group in the middle. I don't think we factored that into our intergenerational programming. So this is kind of what I alluded to earlier when I discussed and spoke about Dr. Parker. So in 2016, in my organization, Strategic Planning, my board chair, a gentleman named David Perdue, he challenged us as the leadership, and he asked us who are the most vulnerable of those we take care of. And myself and the rest of the leadership team huddled, and it was a quick huddle. It was obvious. It was those living with dementia in our environment. So his response back then to us, well, why are we named AG Roads Health and Rehab, which was what our name was then? And it was, of course, because of the industry and the payment system, we were targeting individuals with physical impairments needing rehab. And it's charged to us, well, as a mission-driven nonprofit, we have to change that. We have to find a better way to care for those individuals living with dementia. Back then, I did this heat map showing LTSS and showing individuals living with dementia. And in the few weeks I've had to research for this presentation on younger onset, I actually added this to the heat map. So I do think in our environments, the most vulnerable, not just those living with dementia, but those living with young onset in our environments. Why do we have these challenges? A lot of this has been discussed earlier. Quite simply, when we talk about home-like environments for those individuals, most nursing home inventory in this country is semi-private or shared occupancy rooms. I am 50 years old. That is not the type of accommodation I would want. I think a lot of our young onset would not want to live in those kind of environments. So we're not prepared physically for those individuals. We talk about assisted livings. The reality in this country is most of assisted living care is paid for privately. Most of our states is paid for privately. Thus, financial challenges to be able to access them. We heard a lot today about Social Security, disability, Medicare. Younger individuals literally not qualifying. The 2-year waiting period, which I'm going to discuss a little bit later. That's the period in which individuals go bankrupt. That's the period in which they spend down all their resources and able to take care of their loved ones. And then most importantly, we talk about lack of meaningful activities based on age. Our industry, that residential care industry, nursing homes, assisted living, particularly during COVID, we learned what the difficulties of having meaningful activities means to us. And again, my contention is even in these few individuals I saw in our communities, they lack those meaningful activities. We love bingo in our environments, right? It's great. I would say most of our residents over 80 love bingo, but our under 65-year-old residents, bingo may not be the activity of choice, for these individuals. Keeping on that cost of care, and these figures are low. They just came from one source, so it was very easy for me to use it. So this is the cost of care in our LTSS sector. Home services, you see, adult daycare, $2,000 about. Assisted living, private room, about $5,000 a month. A private room in a nursing home, in the case of my homes, about $10,000 a month to pay privately for it. So it is above the reach of many. Again, not going to belabor for the means of time. Medicare, Medicaid, the eligibility requirements. What we have heard a lot. Especially in the case of Medicare, what I'm hearing a lot from that young onset community is one of is if young onset could become one of those immediate qualifiers, just like ESRD, just like ALS. I'm going to speak about someone that I had a personal encounter with, and I heard, I think it was Matt earlier, talk about ALS and the similarities, and it was striking for this individual to say that they hoped her husband had gotten an ALS diagnosis because he would then have had access to Medicare. And from what I understand, that's a common joke, for want of a better word, within that community. That if that diagnosis would help. And of course, Medicaid, low income, getting to Medicaid. We've had several discussions yesterday. It is a process that it would broke you to get to that indigent point. And our Older Americans Act, which provides so many in-house, so many very, very important care services. Again, not cure services, care services to our community. Of course, are tailored to individuals 60 years and older. So, back in the day, I used to say we have a ageist society. I heard you speak a little bit to that today, Brother John. In that I would think that we did not honor and respect our, elderly population. But I would also say now we do have an ageist society in a reverse way as well. And we need to acknowledge that as a society and as a community. So what are some of our solutions to this? One, absolutely, I think integrated long-term care models versus segregated models. We have actually visited some in Europe and in the Netherlands that provide these type of services. Our friends in Canada do a much better job than we do as well in integrating some of those services. I would say we need to advocate for Medicare coverage for dementia, for all coverages, right? For dementia, especially young onset dementia. We need to expand our coverage options to include adult daycare and respite care. Most of the individuals I've spoken to were very, very pleased with services they received in the adult daycare. However, they were costly. Older Americans Act I spoke about, activities and programs I spoke about. I would like to not quickly, but for the rest of my time, pay our attention to Rod Hall. Rod and his wife, Sharon Hall, who I was really had the benefit of meeting recently. So Rod, absolutely young onset frontal temporal dementia. Rod falls into that exact category that he had to leave his job. Actually, the precipitating factor in him leaving his job was he was a printer, and his hand almost got stuck in one of the printing machines, and he had to leave. His wife, Sharon, who I've come to know quite well, received a nasty email from his supervisor, basically saying that he's started to put on weight. She explained why, because of eating sweets and carbs, because of the illness, and was no longer fit for employment. Sharon and Rod have spent down every piece of their life savings. They can no longer afford to even put him in daycare, which is where, in adult daycare, which is where this picture was taken, which is the environment that he thrives in. And they are at their last. They are certainly at their last. But what really hits me in that story, a few days after meeting Sharon and Rod, the person, Kim McCrae, who introduced me, called me urgently, and she's like, oh my gosh, this was a statement Rod made a few days after. I miss me, the old me, the happy me, the laughing me, the smiling me, the gone me. And I promised Sharon that I would highlight his case because it is certainly not a unique case. And it is a case that I think if we have the will as a nation and as a group that we could help me in my small space of long-term care, acknowledging that we have a long way to go. Would try my best for my organization to do a better job for individuals like Rod and have an alternative living, alternative means of living, alternative means of caring and housing for these individuals. Thank you.
Well, Deke, you've given us a lot of food for thought here. And so we're going to spend, hopefully my council members have questions, points of discussion. I think we've hit on a lot. We certainly have our organizational leads that have hung in here with us. And so it's going to be really important to kind of engage and see possibly what ideas we can start formulating here as to what options we may have moving forward in our recommendations within this population. How can we impact whatever policies to look at bringing down, possibly we've talked about it in subcommittee, bringing down the age of how services and supports are looked at through the Older Americans Act. Can we get that age lowered for people with dementia to 50 or even younger, conceivably? Could it be driven by the diagnosis versus being driven by a cut and dry age limitation? The other thing is when we talk about long-term care settings, this is critical. How do they fit in when they may not have all those comorbidities that someone of an older age would have? Their ability to be physically active. How do we provide for those things when you have an outdoor space that's the size of a patio, where they have physical movement and agility that others may not have? So there's a lot to bring to bear here. So I'd like to see my members online here. What questions do you have, or what points of discussion would you like to bring to the floor? So have we answered all your questions? There he is. Okay, Ken, I see it. Please take the mic.
Yes. So my question would be, what are those most unique care needs that you need to understand in developing the care plans, the long-term care plans for those with the younger onset dementia? Because those who are typically familiar with the older population would not understand well the special needs or unique needs of those with the younger onset dementia. For example, you cannot just put them together with these older population because of the activity needs, the communication styles, even the nutrition and so forth will be quite different. It's exactly as you said. They would have less number of comorbidities, so the needs will be quite different. So say from provider's point of view, what are those unique defining criteria that you got to keep in mind to serve those with the younger onset dementia?
That's exactly the point, and it's a great point, because I think we quite simply do not know enough about the specific care needs of at least in my setting, of the younger onset.
Yeah, I think, Ken, kind of in my response, I think it's going to require multiple stakeholders. It's going to require understanding diagnoses, where currently many people in long-term care settings, whether it be assisted living or whether it be long-term care or skilled nursing, are not cross-trained in multiple dementias. In fact, their training is very limited in dementia in general. I know within the state of California, because I've looked into it, that the CNN training programs only offer limited number of hours into dementia, and it is incredibly generic. So, I think that there's multiple sectors we have to start looking at and affecting to be able to move the ball forward and see what we can do to put our heads together to come up with a comprehensive plan for them to be able to have options, because right now they have little to none. Yeah. Thank you. So, Katie?
Thank you. Ken, that was such a great question, because I think it gets at the heart of the immediacy of what people need. So I would just like to, submit the idea of what Helen just said. Thinking about that, it can be overwhelming and daunting to think about, we need a whole new program. We need a whole new track of services for young onset dementia. That would be wonderful, but that would take a lot of time and effort and incredible research. But thinking about today, just thinking about how can we educate the current workforce to understand the different needs and how there can be an environmental approach, non-pharmacological interventions that can integrate people with different levels of abilities and unique needs into existing community-based programs. So for example, when I think of my dad, who was a veteran diagnosed at the age of 59 with Alzheimer's, of course, he didn't want to go to an adult day health program with elderly people because he didn't see himself as an elder with needs. But when I told him that the local senior program needed volunteers, and then I worked with the staff at the program and talked about what were Dad's strengths and what were his needs. And then they matched him. They found that when items were delivered to stock the pantry, they could pair Dad with a staff member, and he was great at, organizing items on the shelf. He could sit next to another client in the program who had had a stroke and wasn't able to blot his bingo card. And Dad didn't care about bingo, but he cared about feeling important, that he was helping someone who couldn't do something. So what did that program do? They acknowledged Dad's personhood and dignity while integrating him into their existing program. And what I think Brother John had said when he talked about, he approached a program that said, oh, you're too young, you can't be a part of what we're doing here. That is very narrow-minded. There are incredible opportunities to look at what are the gifts that people living with a diagnosis can contribute to their community that could enrich the lives of people at every age and stage.
Thank you. That's very creative. We tried a pilot program where we put the younger onset dementia patients together with the elder population. It didn't work out well. It was too much burden for the staff, who had, exactly as you said, lack of awareness and understanding on how to respond, completely different population. So they simply separated. And what you said, if you were to put them together, having them in a different role, instead of, as a patient, someone who's there to volunteer, that takes a lot of creativity, a lot of work, but that makes sense. It's a different approach that makes sense. Thank you.
Monica?
Yeah, Katie, I love what you had to say. And, I think about what we're talking about is making sure that our staff are trained and really understand how to apply a person-centered care approach to be able to care for those living with dementia. And that really is centered around getting to know the person and their likes and dislikes and preferences. And that will then help to develop that personalized and customized care plan for that individual, and really allowing the teams to be creative and innovative in how can they engage that individual in the way that they want to be engaged and feel meaningful in the activities that they're participating in.
All right, what we're going to do, we've got, if it's all right with the committee members, I think we'd like to roll forward into our next section because our clock is running out here. So what we're going to do is we'd like to bring up to the microphone our next speaker. But I also like to give a little bit of background here, and it's what the next segment is those populations on the margins, those that we don't always discuss or we don't care to discuss, those that may be in the news but not always in the best light. So as we enter the final segment, we'll be discussing populations that we don't consider when calculating the economic, social, and emotional impacts of a dementia diagnosis. These populations are considered invisible, one living in our streets and in shelters, the other behind prison walls. But according to numerous research articles, they have a higher risk of cognitive decline and rates of diagnosis than the general population. We will hear, what we're going to do for time's sake, Dr. Margot Kuschel from the University of California, San Francisco is unable to be here today, so it submitted a video. But due to our time constraints, we may go ahead and just post it online for you. But we will hear from Dr. Michelle DeThomas, and she is going to address the incarcerated. Due to technical issues, we are going to run Dr. Kuschel's while we set up Dr. DeThomas's presentation. So we are going to hear from Dr. Margot Kuschel at UCSF.
Thank you for having me today. I'm sorry I can't be with you in real time. My name is Margot Kuschel, and I'm a professor of medicine at UCSF, where I direct the BENIA Homelessness and Housing Initiative. I'm going to talk about aging, health, and homelessness, findings from the California statewide study of people experiencing homelessness and the Hope Home study. For disclosures, I'm a board member of Housing California, the National Homelessness Law Center, and the Steinberg Institute, but I have no financial disclosures to report. The homeless population is aging. The proportion of single homeless adults who are 50 and older in 1990 was 11%. In 2003 was 32%. But recently, in the California statewide study, we found that 48% of all adults experiencing homelessness in California are 50 and older. This is a generational effect. Americans born in the second half of the baby boom, from approximately 1955 to 1965, have had an elevated risk of homelessness throughout their lives, such that when this large population bubble was in their 30s, the bulk of adults experiencing homelessness, single adults, those without being homeless with their kids, were in their 30s. Now that that population is in their 50s and 60s, so is the bulk of single homeless adults. This aging is anticipated to continue through 2030, at which point demographic shifts will decrease the age again. But the proportion of adults 65 and older in the homeless population is anticipated to triple between now and between 2017 and 2030. In large part, the homelessness crisis is driven by the crisis in affordable housing. What determines the difference in homelessness rates between communities is all about their availability and affordability of housing for the lowest income renters. It turns out that older adults are more likely to face financial challenges, what's called cost burden, as renters than any other age group. In this graph here, you can see that among all renter households, 52% are cost burdened or spending more than 30% of their household income on rent. But when you look at renter households led by someone 62 and older, that goes up to 59%, and 75 and older, 64% are cost burdens. If you look at severe cost burden, those are the proportion who pay more than 50% of their household income on rent. You see the same pattern. Today, I'm going to talk about findings from two studies for which I'm the principal investigator. One is the California statewide study on people experiencing homelessness, which we call CASPA. We released our main report in June of 2023, and we continue to release findings. In fact, we will release a report on aging adults later in May. CASPA is a representative mixed method studies of California adults. We sampled 3,200 adults using weights to draw representative sampling across the state of California and conducted paired 365 in-depth interviews. I'll also be presenting results from the Hope Home study, or the health outcomes of people experiencing homelessness in older middle age. This is an NIA-funded study that I have been conducting since 2013. Every 5 years or so, we recruit homeless adults 50 and older to enter our study using population-based methods in Oakland, California, and then we follow them every 6 months since then. We initially recruited 350 older adults in 2013, an additional 100 in 2017, 2018. The median age of the adults when we admitted them in 2013 was 57. Black and Indigenous adults are dramatically overrepresented in the homeless population. And this is true when you look at older adults. For instance, in California, 31% of adults 50 and older who experience homelessness report a Black racial identity versus 6% in the population as a whole. 3% of older adults who experience homelessness report a Native American or Indigenous identity versus 0.3% statewide. And 14% reported a multiracial identity compared to 3% statewide. You can see that Latinx adults are underrepresented in the aging homeless population. We think this is a generational and demographic effect, and we are seeing more seniors will be increasingly Latino, Latinx as time goes on. In the California statewide study, where the median age of all participants was 47. The oldest person we enrolled was 89. Among single homeless adults are those who are not living with their minor children or not the very young adults who are considered separately. 48% were 50 and older. 41% of those who were 50 and older first became homeless for the very first time in their lives at the age of 50 or older. This mirrors exactly results we got in Hope Home, which has shown between 42 and 44% of older adults were first homeless after 50. In Hope Home, we did some investigations of how those older adults who first became homeless after 50 differed from those who first became homeless before 50 and remained homeless. We found that homeless adults who were homeless before and after 50 had significantly more childhood and early life adversity, leading to low income attainment in early adulthood. They were less likely to ever have had a spouse or a partner. They had a much higher rate of mental health problems, alcohol use problems, traumatic brain injuries, and histories of imprisonment. Among those who were first homeless after the age of 50, though, we found very different patterns. These were adults who hit typical adult milestones. but they worked in low-wage, physically demanding jobs throughout their lives until sometime after the age of 50, a discrete crisis occurred. It was either a job loss, marital breakdown, illness of them or their spouse, death of their spouse or their parent, at which point they found themselves homeless. We found them to have a marked lack of advocacy and social support, meaning that they were not aware of rights that they had, for instance, to maintain their housing. And while they had family or friends, they did not turn to them, feeling deeply ashamed that they were becoming homeless. In CASPA, among the older adults, we found that 19% became homeless immediately after exiting an institutional setting, which were primarily long-term jail stays and prison stays. 46% of older adults entered homelessness directly from a housing situation for which they didn't have any legal rights, which we called a non-leaseholding arrangement, like being doubled up with family, and 35% entered homelessness from a leaseholding arrangement, directly leaving, let's say, a rented apartment on threat of eviction and becoming homeless. Underlying homelessness is really the clash between low incomes and high housing costs. Among homeless Californians 50 and older, the median monthly household income in the 6 months prior to homelessness was $920 a month. Among non-leaseholders, the median monthly household income was $996 a month. 42% were not paying any rent. And of those who did pay rent, the median rent was $412 a month. Among leaseholders, the median monthly household income was $1,100 a month. The median monthly rent was $659 a month, which is both too much, meaning that if your household income is $1,100 a month, you can't possibly afford to pay $659 a month in rent, but also too little, because there is no place in California that you can re-enter the housing market at $659 a month. You will note that the median monthly household income was lower, and that was in part driven by those leaving institutional settings. As one of our participants, a 54-year-old woman, said, "So I've given my whole checkup many times just to pay my rent. I would prefer to go broke paying my rent than go broke and not have nothing at all. Even if it costs my whole SSI check, I don't care. As long as my rent gets paid, that's all I care. My bills, my lights, I don't care." Once people became homeless, their lives were extraordinarily difficult. Among older homeless adults in California, 79% spent the majority of their nights in the last 6 months unsheltered, 21% living in their car, and 58% in a non-vehicle setting, like this photo we took during our field work. Only 21% of older homeless adults in California spent the majority of their prior 6 months in a sheltered setting. Among those 50 and older, 53% reported having fair or poor health, a serious indicator that connotes a high likelihood of hospitalization or mortality in the coming years. 68% reported at least one chronic health condition. 35% reported 2 or more of these. And the chronic health conditions among older homeless adults were serious ones. 42% were aware that they had high blood pressure, almost certainly an underreport. 23% had a diagnosis from a healthcare provider of asthma or COPD. 18% had either a heart attack, known coronary artery disease, or an arrhythmia, or a stroke. 15% knew that they had diabetes, a diagnosis we know is underreported in people with poor access to care. 15% had liver disease, including cirrhosis or chronic hepatitis. 10% had a major cancer diagnosis, excluding non-melanoma skin cancer. So 10% had a major cancer diagnosis, 7% had chronic kidney disease, and 4% had a diagnosis of HIV or AIDS. 43% of older homeless adults reported difficulty with one or more of the main 5 activities of daily living. 23% reported 3 or more deficits or limitations in ADLs. 32% reported difficulty with mobility as measured by the ability to walk across a room. In Hope Home, we found very similar results. 27% noted a mobility impairment. These are people 50 and older as well. 34% reported 1 or more falls just in the prior 6 months. 45% had measured visual impairment wearing their glasses, if they had them. 36% reported hearing impairment, and 48% reported suffering from urinary incontinence. Among Hope Home participants, we conducted cognitive testing, and 26% met criteria for moderate to severe impairment in a screening test for global cognition. 35% had moderate to severe impairment in a screening test for executive function. All of this leads me to say that when we're considering homelessness, 50 is the new 75. As one of our participants said, a lot of shelters they're not equipped for disabilities or handicapped disabled, They don't have handrails in the showers. They don't have a ramp. The disability can be a problem. They don't accept us in a lot of shelters. We found that many older homeless adults had significant symptoms of mental health problems. In fact, 63% reported 1 or more of the following conditions or symptoms. 46% reported significant anxiety symptoms, 44% significant depressive symptoms, 35% noted that they had trouble remembering, concentrating, or understanding, and 13% of older adults experiencing homelessness in California reported experiencing hallucinations. Among adults 50 and older, we saw a high prevalence of illicit substance use, primarily driven by amphetamine use. This is striking compared to 50 and older adults in the general population, and particularly striking if you compare it to people in their 70s who might be a more appropriate comparator. For instance, we found that 26% reported using non-prescribed amphetamines 3 or more times a week, 3% reported cocaine use regularly, and 9% reported non-prescribed opioids 3 or more times a week. Interestingly, nearly all of whom reported co-using amphetamines. 42% of older homeless adults reported a complex behavioral need, either current regular illicit drug use, 30%, heavy episodic alcohol use at least weekly or binge drinking, 8%, current hallucinations, 13%, or a recent psychiatric hospitalization, 5%. 22% of older homeless adults in California reported both having a complex behavioral health need and at least one functional limitation, really explaining that these co-occurring symptoms become very difficult crisis to manage. This is not surprising considering their poor health and poor access to care, that older homeless adults had a very high rate of use of acute health care. 37% of older homeless adults reported an ED visit in the prior 6 months. 25% reported being hospitalized for a physical health care condition, and 5% reported a mental health hospitalization. 28% of older homeless adults experienced a physical assault during their current episode of homelessness. And of those who experienced this, 59% said it was perpetrated by a total stranger. 6% experienced a sexual assault during their current episode. Among cisgender women, 12% did. Of participants who experienced a sexual assault of older adults, 75% of older homeless Californians said it was perpetrated by a stranger. With these significant health conditions and poor access to care, it is not a surprise that older homeless adults have extremely high rates of mortality. Among the 450 Hope Home participants that we recruited either in 2013 or 2017, there have been at least 153 confirmed deaths. This corresponds to age-adjusted mortality rates that are 3.1 times higher than the general population for men and 5.2 times higher than the general population for women. The top causes of death among Hope Home participants were heart disease and cancer at 15%, but 12% of these older homeless adults died from a drug overdose. When we asked homeless adults in California what was keeping them from exiting homelessness, resoundingly they said that the cost of housing was too high. 86% noted that this was the reason that they remained homeless. But there were other barriers to housing in older homeless adults. 41% noted that they experienced discrimination when they tried to rent a place. 44% noted not having the necessary documents like paperwork proving who they were or how much they made. 33% noted their record with the criminal legal system interfered with their ability to regain housing. And 44% noted that they had problems with their credit history or prior evictions, creating barriers to their housing. 32%, or 1 in 3 older homeless adults, noted that they were having difficulty finding a place that could meet their current needs due to a physically disabling condition. Most buildings that I have been in or been to have stairs, a lot of stairs. A lot of these apartment buildings don't have accessibility for a wheelchair or for a left leg amputee. So that's one of the major, and the money. I don't receive enough money each month to live on my own in an apartment. I don't have enough income. In conclusion, the population experiencing homelessness in the United States is aging. Many doing so by entering homelessness for the first time in late middle age. And this population experiences an early onset of geriatric conditions, including cognitive, functional, and mobility impairment. The experience of homelessness is harrowing and filled with despair. Homeless systems need to be responsive to the needs of an aging population, and ending homelessness will require sustained efforts to address root causes, particularly the severe shortage of deeply affordable housing. Therefore, we recommend the urgent need to increase the access to affordable housing options by producing, preserving, and protecting affordable housing and providing subsidies for older adults. We need to expand targeted prevention, looking at people, older adults, for instance, exiting institutions, or those who are at risk of first losing their housing after 50. Once they're housed, we need to provide supports to match people's behavioral health needs as well as their functional and cognitive needs. We desperately need to increase household incomes, including looking at the sources of fixed incomes. Because people are experiencing such despair and danger while they're homeless, we need to increase the outreach and service delivery during homelessness, and we need to embed a racial equity approach in homeless systems, services, and deliveries. Thank you so much for your attention today. Here are some ways to contact me, and I look forward to hearing from you. Thank you.
I want to thank Dr. Cashel for her time, and poor thing put herself through quite a bit to record that video. You could tell she was just recovering from an illness. But this is a lot of food for thought that we're going to take some time to digest. But we're going to move on now to Dr. DeThomas, and I believe she's at the podium, and we should get going. Thank you.
Okay, good. Can you all hear me? Yes. Good afternoon. Thank you so much for this opportunity to highlight some of the challenges faced by those who are aging, coping with serious illness, including dementia in an incarcerated setting. I'll skip since we're running low on time. Well, I came to corrections because there was a lawsuit against the state of California for unconstitutionally poor care within the system. And I was working at UCSF, and we started the Correctional Medicine Consultation Network. And I was assigned to a facility where I spent about 15 years working inside. It has a 17-bed inpatient hospice, a memory care unit, and about 100 skilled nursing beds of the 1,600 statewide. It's a very compelling place to work, and I ended up spending quite a bit of time there. In the last 2 years, I've been working to take some of our best practices and expand them statewide so that we can improve these services for people throughout the state. So next slide. Next slide. Oh, I have no disclosures, and the views here may not necessarily represent the views and opinions of the California Department of Corrections. I'm going to give a brief overview today where we look at a little background data. We think about older adults with cognitive impairment, pre-sentencing, during incarceration, and then post-incarceration and with reentry, and then a few strategies for moving forward. Next slide. So in the United States, we incarcerate more people than any other country in the world. If we compare ourselves to Canada, we incarcerate about 6 times more people. And if we compare ourselves to countries like Norway and Denmark, about 10 times more people. Next slide. So the Pew Charitable Trust did a study in 2008, and the numbers are pretty much the same, but we incarcerate about 1 in 100 Americans are currently incarcerated. That means if you're a man between the ages of 20 and 34 years old in this country, there's a 1 in 30 chance that you're currently incarcerated. If you're a Black man between those ages, there's a 1 in 9 chance you're currently incarcerated. What that also means is there's about 2.2 million children with an incarcerated parent, or 1 in 28 children. Next slide. So some of the contributing factors, we do a lot of long sentences in this country. So 1 in 10 people are sentenced to life in prison. That's about 200,000 people nationwide. Reasons for this include 3 strikes laws, mandatory minimums that don't allow judges discretion. So if somebody's in their court with cognitive impairment, with a history of childhood trauma, with mental health issues, they can't necessarily give a lower sentence. There's limited parole opportunities. We have a lack of mental health, substance use, and geriatric care services in the community, as you all have been talking about. And then there's something that needs more research, but increasing conviction rates for older adults. In 2000, about 3% of arrests of adults were older adults. In 2021, it was about 8%. So rising number of older adults being convicted of crimes. And again, Margot's study gives us one reason: increasing homelessness among older adults, and also lack of resources for people with cognitive impairment is clearly one of the factors. Next slide. So I can't not mention the disparities in this. It's important to recognize that this disproportionately affects people of color. The reasons for this include disproportions at every level, from who gets pulled over to who gets who's able to make bail, who's given the opportunity to have bail, who is charged with a crime or not charged with a crime, and what degree of crime that might be, whether it's manslaughter, first-degree murder, second-degree murder. When we look at a Black man and a white man with the same crime and a similar criminal history, on average, the Black male will get a 19.1% longer sentence. When we look at life without the possibility of parole for nonviolent offenses, 65% of people receiving those are Black. When we look at life sentences for children, 80% of those are children of color, and 55% of those are Black youth. When we look at people with life sentences in California, about 60% of those are people of color. Next slide. We also have to look at the amount of adverse childhood experiences experienced by this population. 78% of my patients have had 4 or more adverse childhood experiences versus only 16% in the community. So my patients have done harm, but they have been harmed. We also see, because of this, a large amount of mental illness, substance use disorder, and this concept of accelerated aging. So when we look at the chronic disease burden and degree of functional impairment of people who are incarcerated, they tend to be equivalent to people 10 to 15 years older in the community. So when we talk about geriatrics in this population, we usually use 50 or 55 as the cutoff rather than 65. Next slide. So the population is aging. Nationally, we've seen a 400% increase in the people 55 and older behind bars between 1993 and 2013. In 2021, it was 20% of the population in prison in our country is over the age of 50. And with current trends, we expect that about 33% of the prison population by 2030 will be over 50. That's 400,000 people, many of whom will develop mild cognitive impairment to dementia. Next slide. Obviously, this population faces some very unique challenges. Can you imagine being mobility impaired in this setting, or losing your vision for the first time when you're incarcerated, not being able to hear either the people around you or maybe an order from an officer? You have to cope with serious, profound isolation, serious illness, and end-of-life care without your family around. Cognitive impairment can lead not only to victimization, but it can lead to rules violations because you didn't understand what the rule was and nobody's diagnosed you yet. So instead of, you get a rules violation, which may seem small. It may be for something as little as not getting to work on time. But when you go before a parole board, if you have rules violations, they don't believe that you're ready to go back into society. So we have older adults who are being told they need to work on their post-release plan. They need to gain more insight into their crime, and yet they have a significant cognitive impairment that does not allow them to be able to do that. Obviously, this situation is unsustainable fiscally, ethically. It causes a lot of moral injury to staff. It can be a very challenging place to work when you see people's needs, but you don't have the tools to address them. Next slide. So I show this picture. This is actually the hallway at the prison where I worked for many years. You see a mobility impaired gentleman with the cane guiding a visually impaired man with an orientation stick. And I show this because this is more of what prison looks like these days. It's not what you see on TV. A lot of wheelchairs, a lot of walkers, a lot of CPAP machines and oxygen concentrators and equipment in very small spaces. Next slide. So I'm going to tell you a quick story about a patient we had about a year ago. So Ms. K, she was living alone in a mobile home community prior to her incarceration. Her family had noted that she was declining cognitively and was also having a disagreement with her neighbor. Not knowing what else to do, the family reached out to the local police as they were concerned for her safety, but there were not services that the police could offer the family. One day, Ms. K came to believe that her neighbor was trying to poison her dog. She went to the neighbor's house and she had a broom in her hand. After a verbal altercation, she swung the broom. It hit the neighbor in the throat, collapsed her trachea, and the woman died. Ms. K was arrested, placed in prison for murder, and over the next 8 years, her dementia progressed. She became bedbound, incontinent, and unable to meaningfully communicate. Her family was devastated. Her daughter told me that she had never committed a crime in her life, and even when she was a terrible teenager, she'd never been violent. Ultimately, on the day before she died, she was released under a compassionate release program to hospice, and her family was able to be at her bedside for the last 24 hours. But this is a terrible story for the victim, the victim's family, Ms. K and Ms. K's family. So how do we provide more community supports for older adults and their families so they don't end up in these situations? So the UC San Francisco Criminal Justice and Aging Project interviewed police officers, public defenders, judges, and they were told many similar stories. One public defender said, his crime was to go into a coffee shop and steal the tip jar. He would always go back no matter what. Even with a stay away order, even though we talked to him every day, he would go back to the same coffee shop and steal the same tip jar. I think if we had been more educated in what was going on, dementia, we could have done a much better job. He's still out there floating around the system. A judge spoke about a 75-year-old woman who had been arrested for abusing her elderly husband of many years. She spent many months in jail, and during the trial, she was diagnosed with a frontal lobe tumor that explained her bizarre change in behavior and personality. I had another lawyer share with me that after a cognitive impairment training, she had a case where one of her clients was being tried for a serious crime that was related to dementia. Instead of incarceration, because of her newfound knowledge, she was able to have him conserved by the county and placed it in an assisted living facility rather than being sent to prison. So we need more training for police officers, lawyers, judges, etc. We also need to grow the links between the police and community resources. When a policeman gets a call at 3 a.m. on a Sunday, he has two choices, the emergency room or jail. There's really not a lot of other options when dealing with an older adult, and they don't necessarily know which of those two things the behavior is related to. There's something called collaborative courts. We have mental health courts, substance use courts. We have courts for veterans so that the resources available to those populations can be brought into the system and the judges will have an alternative to incarceration. And we need something similar for older adults so that judges have choices. In Michigan, one of these mental health courts saved $7 for every $1 spent, and it reduced recidivism by 300%. So we know these programs can work. Next slide. During incarceration, so in our facility and in our program in California, we've started to do a lot of training. We've trained doctors in geriatrics and palliative care, in cognitive impairment. We've developed memory care unit trainings that include officers, so the officers know how to speak to people in a way that allows us to guide them to more positive behavior and not ask questions and do things that exacerbate the behaviors. We need a lot more understanding of decision-making capacity. We have people inside of our prison systems who are making decisions that they are not able to make that have poor outcomes because of that. I don't want chemo. I don't need to go to the parole board, but they don't have the capacity to do that. So while we want to respect autonomy, we also want to make sure that we are being beneficent and supporting people who don't have that ability. We need programs for older adults. Prison is extremely isolating at baseline. And once you're an older adult, especially with cognitive impairment, we need programs to support people. We also need those spaces to feel more normal. It can't feel like prison. Prison is militaristic. It's very restrictive. It lacks the flexibility that we need to be able to support people who are either at the end of life or having cognitive issues. We need more medical social workers in prison so that we can help support people with advanced care planning, with that decision making, having a surrogate, being able to find family. Many of our families have been lost due to prior homelessness or substance use disorder or mental illness. And by reconnecting with family, then we can develop reentry plans that can be successful. And then using robust peer support models. And I'll talk a little bit about that. Next slide. So this is our hospice. It's not particularly amazing, but it's normal. It feels like a normal nursing home. The way we interact with the patients, the way the patients can come up to us, the way they interact with each other, and the way families visit. It's very, very different than normal prison. Next slide. This is just one of the rooms. You can see there are bars, but there's shutters over the bars. The porcelain toilet and sink really jar me because most prison cells have that stainless steel toilet sink combo thing. So this feels really different. The quilts were made by a church in the community so that everyone has that. And then we do legacy building. So our patients are people who are dying in prison, but that's obviously not all of who they are. And so the social workers work with them to think of the positive things in their life, looking back at how they were a good father. They were a very skilled mechanic before they came. We have a lot of men who are veterans and they're very proud of their military work. So we try to help them emphasize that and refocus. Next slide. This is through a grant through the California Healthcare Foundation. We were able to create this beautiful garden. We have baptisms, marriages, we've had memorial services, and this is where the family can visit. So a much more normal and uplifting space than you'd normally get. Next slide. So we recently had a patient, he was actually living in a facility that was extremely isolating. He had very significant dementia. He'd basically been in a room by himself for 5 years. Very depressed on top of that, very unstimulated cognitively. We got him out of that facility and brought him here. We rolled his bed out to the garden, and he had tears running down his face. There are hummingbirds, there's butterflies. The incarcerated peers would bring him rosemary and lavender, and he just kept saying, "This is delightful." He'd been in prison for over 40 years and hadn't seen anything like that. So you can really impact people's lives, but not only their lives, the lives of their family. So this gentleman, over the next few weeks of actually having people talk to him and support him, he began to speak, and he was able to tell us lovely stories from the 1950s. He had very poor short-term memory, but he would remember all the songs from the 1950s. Within 2 days, our chaplain was able to find his family. He had left Pennsylvania because of a substance use issue, ended up in California. But because of this, we were able to reconnect him through video visits with his daughters, who were 5, 6, 7 when he left. And they were able to develop as adults a really meaningful relationship with their father before he passed. So these are all things that we could be doing inside of prison systems nationwide. Next slide. We also created a memory care unit. So the staff, as I mentioned, are specially trained to work with the population. We have a ton of activities to keep people excited and engaged. We have social workers. We were able to, and I can't tell you, it was actually quite challenging to get the doors painted, but we were able to get the doors painted different colors, just like in other memory care places, so people could identify their doors. We couldn't do memory boxes, but we were able to print things out from the internet that were meaningful to the patient, laminate them and put them at the door, which helps the patient identify the door, but it also helps staff, because we have a lot of rotating staff, know like, oh, right, Mr. Smith is the gentleman who likes the Dodgers and turtles. And so they're able to remember that and use that to have positive and more human interactions. We have contact sheets where we actually, so that the officers know. We had one patient, he was from Cuba. He was a boxer for many years in Cuba, and he'd like to greet you. You know, he's almost 80, but he'd greet people like this, which can be very concerning in this setting. So we made sure that in his contact sheet, it was very clear this is a friendly greeting. If you're a new officer in the unit, you just have to say, "Oh, were you a boxer?" And he'll start telling you his whole story. And then using the peer support program. Next slide. So this was a New York Times Magazine article from May of 2018 that focused on our peer support workers in our hospice. These gentlemen are extremely well trained. They go through over 80 hours of training. They know how to support older adults at the end of life and people with dementia. They, in our setting, nobody dies alone. If people are near the end of their life, there's volunteers who come and sit at their bedside 24 hours so that nobody dies alone. Most of these peer support workers committed violent crimes when they were 16, 17, 18, 19 years old and have life sentences. And now this gives them an opportunity to have meaningful work and to be able to give back, because now they're completely different people and they want to give back. It supports the patients, the peer workers, and obviously it supports staff. Next slide. One peer support specialist said, "When I first joined the hospice program, I didn't fully understand who we were going to help. I've learned a lot more about myself in the past year. I found abilities and strengths I didn't know I had." And I love this picture because to me, it's like the picture of the rabbit and the duck where you see one or the other. So it could either be a young man supporting an older adult, or it can be an older adult mentoring a younger man. And that really is how the program works. Next slide. So even though we've managed to create an environment where our patients do feel supported, nobody wants to die in prison, and a prison will never be an appropriate place to take care of people with dementia. So a significant amount of my work is working towards release and reentry. Next slide. I'll skip this just to say that these patients are very, very low risk of recidivism, and they cost an enormous amount of money to the state. It's caring for people in the most high cost possible way you could, even higher than the emergency room. Next slide. So some of the barriers to release. We have to be able to communicate with decision makers who are looking at release, parole boards, courts, and we're working on building that communication. But there's limited supportive housing options for release and reentry. These are societal changes faced by all older adults, as Margot mentioned. There's a lack of social support networks. And then the added challenge of this population is the stigma of incarceration. We had one nursing home that we'd been trying to get to take one of our patients through a compassionate release program, and they had said, no. And we broke them down. And she was like, okay, we'll take one patient. And she took Mr. M. Mr. M, he walked out the door. His O2 sats were about 70. I wasn't sure he was going to make it, but he got out. His family actually lived in the surrounding community, were able to come into the facility, bring him all his favorite food, love him, share their joy at being able to spend time together. They spent about a week together, and he passed away. The nursing home staff called me the next day, and they had said they wouldn't take another patient for 6 months or a year. They called, they said, his bed's open, we'll take another patient. So sometimes just overcoming that stigma and having them realize that they can be really part of something super meaningful for a family, and they wanted to do more of that. Next slide. Every state has a program for compassionate release or medical parole, but it tends to be very underutilized. In California in 2020, we had about 16 people released that way, and that's with a lot of effort. We need some really significant changes in terms of how we communicate with the courts, how we track how people are moving through the process. And then we had some legislative change that actually added dementia as one of the reasons that people could be released. In 2023, I'm proud to say that we had 63 people able to release to the community and be with their families at the end of life. But having a post-release plan or a place to go is the number one limiting factor at this point. Next slide. So moving forward, I tried to align, the numbers are the National Plan to Address Alzheimer's Disease Goals 2023 goals. So we would need to grow community supports to help prevent crimes like Mrs. K's. We need to train police, judges, and parole boards, along with parole officers. We had a geriatric training in Hawaii with parole officers, and one of the officers, we put the glasses on to simulate macular degeneration, that whole exercise. And at the end, we had a parole officer who was trying to put her psych pills into a container, and they were going all over the floor. And at the end, she said, gosh darn it, now I'm going to have to be more empathic. And she was joking, but she was also serious. When that older adult is a half an hour late for their parole appointment, don't send them back to prison. Understand what it was that led to that and how complicated it can be, and then give them more supports, not less supports. A loss of liberty is the punishment, but once people are inside, we have an obligation to provide humane care. Our goal should be to make people better neighbors, not to continue to degrade and punish. Correctional staff need to be trained to support those with cognitive impairment. Age-appropriate housing and supports need to be available in the community. The use of peer support specialists inside and upon reentry. In California, we have an expansion of Medicaid called CalAIM, and it really focuses on using people with lived experience to support those coming out of prison. And that's one place where I think we have a really good opportunity, not only to give people meaningful work when they get out and use some of the skills they've developed inside, but also to support older adults coming back. And then finally, we want to legislate for compassionate release and medical parole that addresses the needs of those with dementia. That's it. Thank you so much for having me. I really appreciate this opportunity.
Dr. DeThomas, thank you. You've provided so much in the way of insights that I'm sure many of us were never aware of. And the issue of, taking people that deserve to be treated humanely, we all do, every single one of us on this planet. And even though they may have made mistakes in the past, at end of life, each of us deserve, like they have presented here today, deserve not to be alone and not to be vilified. They need to pass and transition to the next life, if there is one, with our respect and dignity. So I want to thank you for the efforts you've made within California, and hopefully others throughout the nation will learn more about what should be done. We are well past time, so it will be up to the committee members. If you have any questions, please, you can raise your hand. But if at this point you decide that it is time for us to adjourn, then we will do just that. So does anybody have any questions that they'd like to ask? Okay. Well, Helen, do you want to adjourn at this point?
Well, first of all, thank you so much to our speakers for bearing with our technology issues and for being here today to speak to us about all of these important issues. I think we sort of acknowledged the beginning of this year, and it keeps coming up, the breadth and the depth of the topics that NAPA covers. And you could just see between the last 2 days, which are only maybe a quarter of our work, the depth and breadth within those two topics of issues and policy changes that we need to make for the good of the American people, especially the most vulnerable among us. And so with that, I will wrap us up. Our next meeting is a little bit later than usual. It's August 6th. It's a Monday. And then the meeting after that will be October 21st. So mark your calendars. We'll also send a calendar appointment. And thank you so much to everyone who joined us locally and online.
Produced by the U.S. Department of Health and Human Services.